A cruise ship, international passengers, medical teams on alert, health authorities quietly stepping in, and suddenly, a rare diagnosis starts appearing again in global health reports: hantavirus infection. Most physicians would not expect to hear that in a routine clinic day. But that is exactly the point, because the cases that change outcomes are not the ones we anticipate. They're the ones that look ordinary at first. A patient walks into a clinic. Fever, fatigue, body aches, maybe a mild cough. Nothing that immediately raises alarms. It looks like flu. It sounds like flu. It is treated like flu. But sometimes it is not flu. Hantavirus infection often begins in a way that is almost impossible to distinguish from common viral illness. Early symptoms blend into everything we see every day in outpatient care. But in some cases, the disease can progress quickly into severe respiratory failure, requiring intensive care support. And by the time the respiratory symptoms appear, the clinical window for early intervention may already be narrowing. So what makes the difference? It is not always lab results. It is not always imaging. It is one thing: exposure history, rodent exposure, cleaning an old shed, working in barns or storage spaces, traveling through rural environments, dust exposure in enclosed areas. These are the details that often decide whether a case is recognized early or missed entirely. And here is where modern clinical practice becomes complicated. In a busy clinic, you are managing volume, time pressure, documentation, follow-ups, prior authorizations, billing systems. You're not just diagnosing patients. You're managing a system that constantly demands attention in 10 different directions at once. And in that environment, small questions get skipped, not because clinicians do not care, but because the system does not slow down long enough to allow every detail to surface. Recent public health alerts and international case monitoring have reminded the medical community that rare infectious diseases are not disappearing. They're simply harder to see when early signals are buried in routine workflows. And that is the real challenge. Not recognition after deterioration, but recognition before it happens. Here is the uncomfortable truth. Most misdiagnoses are not knowledge failures. They're process failures. The patient was not necessarily mismanaged because the disease was unknown. They were missed because the right question was not asked at the right time. So what do we do with this? We start with something simple. We change the way we think about routine visits. We make exposure history a standard part of respiratory complaints. We slow down for the details that matter. And we build systems that support clinicians instead of overwhelming them. Because here is what hantavirus really teaches us. It is not just about a rare virus. It is about how fragile early detection becomes when clinical systems are stretched too thin. So if you're a physician, a clinic owner, or a part of the care team, here is the reflection. In your current workflow, are you consistently asking the questions that uncover hidden risk? Or are those questions getting lost in the speed of daily practice? Because sometimes the difference between a routine discharge and an intensive care admission is not a test result. It is a single question. A question about exposure. A question about context. A question that changes everything. If this resonates with your experience in practice, share it with a colleague. And more importantly, take a moment to review your intake process. Because early recognition does not start in the ICU. It starts in the clinic. Repost this if you believe better outcomes begin with better questions, not just better treatments.